In 1992, this also established the Minority Health Advisory Council, which is a body of 15 appointed people in North Carolina, 5 appointed by the governor, 5 appointed by the Speaker of the House, and 5 appointed by the President Pro Tem of the Senate, that help to advise North Carolina, its legislature, its governor, and just the regular people of North Carolina on minority health issues. And so, 2001, we changed our name to what we're known as now as the North Carolina Office of Minority Health and Health Disparities. And hopefully, as we celebrate 25 years in existence next year, in 2017, we are looking to change our name again to the North Carolina Office of Minority Health and Health Equity. Our mission is to promote and advocate for the elimination of health disparities among all racial and ethnic minorities and other underserved populations in North Carolina, with a vision that all North Carolinians will enjoy good health regardless of race, ethnicity, disability, or socioeconomic status. To look at how we sit in North Carolina state government structure, we are a part of the North Carolina Department of Health and Human Services within the North Carolina Division of Public Health. Looking at it with the connections to the national office, we are part of the National Association of State Offices of Minority Health. So that means there's an Office of Minority Health within all 50 states in probably about 12 to 15 U.S. territories. And we look down how it breaks down into what we do. We offer a few programs and services and technical assistance across the state. One being our Health Equity Lunch and Learn series, where people currently they come to the Division of Public Health in North Carolina, and we have different topics that are connected back to health equity, and we have presenters on those topics. We started in December of 2015. We brought in Dr. Damon Tweedy to talk about his book, Black Man in a White Coat, and had almost like a fireside chat with over 90 people here at the Division of Public Health. And this was ranging between health professionals and also community people and students. And it was a really good conversation. And so we've carried that on with different topics. Our next Lunch and Learn will be next Tuesday. We'll be looking at health careers engagement and looking at health professions diversity and pipeline programs that are in North Carolina around health careers. And so if you're able to join us, that'd be great, but that we can send that information out as well. We also have the Community Health Ambassadors Program, where we connect people within the community to empower their communities and be a resource within their communities about certain health topics and connect back to the resources that we have across the state. And this also feeds back into the larger community health worker initiative that we are rolling out soon at the state level. We also have our cultural and community health initiatives. This covers the work we're doing with faith-based communities and communities at large, as well as the cultural and linguistically appropriate services program, or the class that are connected to the national class standards. And those the work that we're doing there across the state of North Carolina, especially within our local health departments and other health agencies. And as we have talked about before, we have the Minority Health Advisory Council that meets quarterly. So let's jump right into it. What do we mean when we're talking about health equity? Health equity is something that has been a buzzword or a buzz phrase, but what are we really talking about? What we're really talking about is that when you have everybody has access, or everybody has have these levels of care that they can tap into without any type of differences, without any type of barriers, and that nobody is disadvantaged. And so everybody has opportunity to access care in a manner that is not restrictive. When we're talking about health inequities, we're talking about the exact opposite. So we're talking about those unfair differences that may be, linked to social or environmental or economic disadvantages, or even historical trauma or historical barriers that have been put in place that infringe on people's rights or their norms. But the key word for both of these definitions is fairness or the lack of fairness. And then when we're talking about health disparities, we're really talking about that measurable gap from one group to another group or other groups. So when we're talking about health disparities, we're talking about um, the measuring stick of white people and everybody else in this country when we're talking about health disparities. If we look at it in terms of, I know this is time for the Olympics, so if you're looking at it in terms of a track and field event, in terms of the total viewpoint of how this works, health equity would be the goal, the ticker tape that you run through after you finish the race. That's where we're trying to get to. We're trying to get everybody to a point of health equity. And so while we're running the race, not everybody has started on time. People start in different lanes. And so there are groups who have advantages where they start early and they don't have any barriers. So the groups that have barriers or obstacles or hurdles to jump through, those would be the inequities. In the distance between the group that starts first and has no disadvantages and the groups who start later and may or may not have disadvantages, that is what we call the health disparity. So when we're looking at equality versus equity, there's different things. And this slide will show you that people sometimes actually use these words interchangeably, but it's not. And so the first two parts of this, like the picture in this slide may be very familiar to people, but this is a more recent, the third one is a more recent picture that has been included. So a lot of us have seen with equality, everybody gets the same thing. So you see that in the first picture. In the second picture, you see more of equity, where people are kind of met where they are. So that's where when we're talking about equity, we're talking about meeting people where they are. And so in the third picture is a cause for even greater discussion because it takes away the barrier of the fence, and people are really, naturally placed as they are in life. And so this is a good starting point in the conversation, because we need to know and make sure that we're not confusing equality and equity, because when you do, sometimes people still lose out. So what influences health equity? Well, this is a nice little thing called social determinants of health. And I like to say social determinants of health and life, because it's all interconnected. But some of the things that we connect with social determinants are housing, education, income, employment. And so these things, as well as others, as well as like capital, these things have influence on how we behave in terms of our health behaviors or our life behaviors, and then how our health is impacted by that. And so we'll see some information to connect back to this, especially when we're looking at North Carolina. So if we're looking at North Carolina population by age and race, ethnicity, you'll see under 18 there is differences between the 18 to 64 ranges. And so as mapped out by these color schemes, in the 18 to 64 range, whites are seen as 65% of the population. And this information is coming from the North Carolina Center for, the State Center for Health Statistics in North Carolina. And so you'll see that whites are 65% of the population. But if you look at the groups under 18, you'll see there's a stark difference. Whereas the population went from 65% to 56%. That means that population growth is declining while other groups are increasing, and those other groups being African Americans, which were 23% in 18 to 64 and then increased to 25% in under 18, and Hispanic Latino, which goes from 8% from 18 to 64 to 15%. So you're seeing the growth, and it's even projected that by 2050 in the whole country, that the side of the table, the pie that we see as minorities will be the majority as a whole. So we're looking at a huge population shift that's actually going not only in just North Carolina but across the country. So bringing this back to education, we're looking at the numbers of education in North Carolina versus um, the U.S. is pretty similar in terms of age, adults age 25 or more that have a high school diploma. And then the numbers are also kind of similar in terms of adults age 25 and more that have a bachelor's degree or higher. The issue with this is that right now it is 2016, but by 2018 it's projected that 63% of jobs will require a post-secondary education. And so that's a huge part of the labor force. And if the adults that are 25 or older are significantly not having those degrees, they're going to be left out of jobs, thus having an impact on our health. When we look at poverty in the state of North Carolina, 1 in 5 North Carolinians live in poverty. You can see the breakdowns by poverty by race of all ages, but you can also see the poverty types by family, and you're seeing that the female head of household is more likely to live in poverty than that of a male head of household or a person, or a family or a group of people that are married with children. And so we're seeing discrepancies there as well. Looking at employment. In North Carolina, last year the unemployment rate was 5.5 for the year. And I use 2015 because we're still in 2016, so these numbers will fluctuate. But to give us a point of where we are, this doesn't sound as bad as it looked in 2010, but here's the problem. When you break it down by race, white people had unemployment rate of 3.9%. Hispanic Latinos had a rate of 6.9%, and African Americans in that same year had a rate of 9.6%. And then based on the counties that you may go in North Carolina, the rates could be higher. And so when we're talking about how and why this influences health equity, it's because all these things are interconnected. You know, we have policy level connections and community and organizational, interpersonal and individual level connections onto why all this affects how we live and how these things are our social determinants of health. And going back to, you know, how we are all connected to that, it plays a major part of who we are. So I won't go too heavy into this conversation, but I will give you some homework to make sure that you look up Levels of Racism, a Theoretical Framework in the Gardener's Tale by Dr. Kamara Phyllis Jones, who is the president of the American Public Health Association. And so in it, she goes through some themes. She uses this allegory to kind of talk about institutionalized racism and personally mediated and internalized racism through this tale of a gardener. And so when you get a chance, please, you know, have the time to let this digest and sink in. And if we're able to send my slides out after this presentation, I have hidden some, as we call, Easter eggs into the presentation. And under the part where it says gardeners and under the part that says tale, I actually have a video of her doing a TED Talk that breaks this down even further. So this is something that is really connected to a lot of the work we're doing, especially when we're looking at the foundational structures of what racism truly is. And racism actually looks at the issue of unshared power between one group and another group, or one group and other groups. And so when that power is unshared, that's where we're really looking at the the true definition of racism, because we're looking at the structural foundation of what these issues are and how they play a part in our social determinants, our health and well-being, and our health outcomes even. So when we're looking at the framework, there's what we see the social, ecological, and medical models that are looking at the upstream and the downstream, where we have discriminatory beliefs and institutional power and social inequities that are connected also at the individual level and the systems level and genetic levels, where we have risk factors and behaviors, disease and injury, and then leading to mortality. And so these are things that we keep in mind as we start talking about what these issues really are. So as we get into the conversation of community engagement, we talk about purposeful partnering. And as we in this office come up with the definition, we say that it's the intentional relationship between two or more people or organizations with shared and common interests to achieve a specific goal or aim. So what does this mean? It means as you're connecting with communities, the first thing you have to do is listen to communities. A lot of times we're so caught up in having our agendas preset before we go into the community. And if you really are about change and purpose with the work that you do, like, you have to listen to what the community has to say. Sometimes the community just wants to get things off their chest. Nobody's had a time to listen to them or for them to express their feelings about issues. So it's always good to come into a space and listen. So step one of this four-step process, the 4 C's, as we like to call it sometimes, is being concerned, making sure that you're communicating, then making sure you're connecting, and staying committed to what you want to do. And it's a cycle. So there are different levels of all of these, but it's making sure that we're connected at a point with each other that we can go through all of these steps. So we have to look what the issues are. What are the issues that we need to address? And are we coming in with these issues predetermined, or are we coming to a space that's flexible? A lot of times if we're working with grants or other funders, we have sometimes no say-so in terms of, getting around what we're here for. But what helps us is that if we're flexible enough to at least acknowledge what the community concerns are. So what is the information and input that you want from the community? So a lot of times we are dealing with community at a level that's comfortable for us, but to be in true community, sometimes you have to be uncomfortable. And then you also have to be able to hear what they're saying to you, and not just hear it. You're not just listening, but you're also trying to figure out what's the best level to engage in a process to take that information and use it for a positive purpose. So you look at what's the best way to process, what's the best way to get the information. Are we looking at surveys? Are we doing focus groups? Are we doing town halls? What is the best way to connect? Social media has been a great connection tool, and it gives a voice to people who sometimes don't have a voice. But within that, what are we finding out about the information that's collected? And does it change anything in terms of how we are going to approach what we're doing? And so that information should help us guide what we're trying to do as well. And so there's some other ways in this slide that we can kind of look at the processes even more in depth, and looking at the development idea, the plan, and then making sure that everything aligns. And then always go back to make sure you heard everything correctly or you captured everything correctly, and we're not just moving in the space of, oh, we think this is what they're trying to say. That is always something that can derail us very early on in the process. So then there's different levels of engagement. So we have to look at where we and our partners fit into these levels of engagement. And so is it a passive level of engagement? Is it reactive? Is it participative? Is it empowering, or is it leadership? And so all these have different roles and functions and outcomes based upon where we are. Because we don't want to get to a point where people are derailing the process. So we want to make sure that people are engaged. Because if people are not engaged, then it's just more of we're telling or dictating what's going on in the community to that community who may live there. But then the worst side of things that could happen is that these people who are not engaged could become actively disengaged and try to tear down the whole structure of the relationships you're trying to build in the community. Which brings us to a theoretical concept that I've created called relationship rhythms. And so it talks about how we connect in communities and how we partner and the different strategies that come along with that. So when we're trying to get into communities, we have to figure out what is the relationship rhythm. What is the rhythm that the community always has? So if you look at it in terms of jump rope or double dutch, you kind of see that there's people on each side that have the rope that can represent community as a whole, or it could represent community and a partner. And so as the people are swinging the rope, that is what we call the community rhythm or the relationship of that community. And so what people are trying to do is figure out how to be actively engaged and involved in that relationship. So you're trying to find a point of entry, and that point of entry is also seen as how we access the community. And so we want to figure out how to get the rhythm to be able to engage. If you run in without taking a step back to analyze what's going on, then you can mess around and hurt yourself and hurt the community because you have not taken the time to respect that community relationship or to find that rhythm or that point of access within the community. So when you find the rhythm and you become actively engaged, then you find out how to maneuver into that space. And so you find that relationship rhythm in the community. You're doing your due diligence, you're working with people, you've gone through the proper steps. And so you now have figured out how to get into that relationship rhythm with the community. Now, the other piece of this concept is that you also have to figure out how to jump in and how to jump out. And sometimes when you jump out, maybe it's your turn to cultivate other relationships in that community. And so maybe you are the ones that take the rope and the other people can jump in and out of the relationship with that community and find that rhythm. So when we talk about this, we talk about finding the relationship rhythm. We talk about identifying potential community partners who who needs to be at the table? Who's missing from the conversation that is a vital piece of making this happen? And so you do that by observing and researching that community environment. As we were saying, you just can't jump into a rhythm or jump into that relationship with the community without processing and understanding what it is that you're jumping into, because that could be hurtful for you and that community. So you have to connect with the gatekeepers to find those entry points. And as you do that, it helps you build your trust and capacity. So you're building trust with the community and also want to make sure that you're bringing something to the community and not just being lecherous and just leeching off that community. And so helping them build their capacity will also help you build your capacity as well as being a key cog in the wheel of this community relationship. And so 5 is the most important that should be happening throughout the whole piece, is that you're involved and engage the community partners in the entire process. If you're trying to work on coalition building, if you're trying to work on just a program or anything, you have to make sure that the community is involved and engaged throughout the entire process, because that will alleviate some of the issues that go on. So I have given you relationship rhythms by myself. So this also is a good segue into talking about how we need to build coalition. So coalition building is the process by which parties, individuals, organizations, or nations come together to form a partnering of groups in order to achieve a common goal or purpose in a joint activity. And so that's the definition that we use when we're talking about coalition building, because we know that coalitions bring people together, helps to negotiate agendas, personalities, and competing interests. And we also see that they allow for the collective input and united voices and provide a structured way of advocacy. So there, there was an interesting learning lesson moment for me when I was recently at Disney. I went to Disney with the family and said, "Hey, let's go on this little ride where you're riding through where they keep the animals." And we get to a point, and the driver stops and says, "Oh, if you look to your left, those are the cheetahs." And I learned something interesting, and he told us that a group of cheetahs is called a coalition. I was like, huh, well, that's interesting. Since I just did a webinar on coalition building, let me see what they're trying to talk about. And so we learned that when the cheetah are more connected, when they're together, they have a common purpose or a goal, that they are able to have strength in numbers and to achieve that goal, whether that goal is to fend off an attacker or they are the attackers. And so it was very interesting to me. I was like, oh, wow, I'm learning something. But it also told us that the coalitions don't stay together forever. Coalitions actually are temporary partnerships that will lead us to a certain goal. So the other thing they told us about cheetahs was that they can achieve speeds of 60 to 70 miles per hour in short bursts of 5 to 10 seconds. So what I took away from that is that when we're looking at coalition building, when we're looking at trying to make impact, it's not that these coalitions will last forever, but it's that these coalitions have a purpose, and they have a measure that we should all be looking at is either coalition should evolve, coalition should dissolve. So the coalition evolving means that we've gotten to a point where we're getting the outcomes we need, or we may not be getting the outcomes we need, but we need to make sure that there is not a life of this coalition that will actually hinder work being done in an efficient and effective manner. So it may need to evolve into something else, or it may need to dissolve. And so we don't want to get to the point where we have coalition in name, but the true intent of what we're trying to do gets lost. And so coalitions in our communities can help us identify gaps, especially if there's gaps in voice to some of the issues that we may or may not know about. It helps to avoid service duplication, making sure that we're not trying to reinvent the wheel. Allows for better understanding of the needs. This is a good way for organizations who may or may not be connected to community people or community organizations or even faith-based organizations to understand what are the true needs of the people. When I was working with the General Baptist State Convention, North Carolina, we would oftentimes go into communities to just hear what they had to say. And we're going in there with a program for them to stop smoking, but they are really trying to keep their lights on. And so the priorities will shift because you have a better understanding of what those needs are. And it provides forum for diverse perspectives, because we all know what we know, but it gives us a better footing for us to know what each other knows in a collective voice, to say we have a different way of looking at this. If you've ever been involved in anything dealing with art, you can look at the same piece of artwork and see totally different things based on other people's perspectives. And so back to the differences between a coalition, alliance, and a network. A coalition is seen as more formal collaboration structure, where alliance is even of a more short-term relationship between organizations, and then the network that we look at is seen as more flexible associations of groups. And so sometimes a lot of these terms are used interchangeably, almost like the difference between equality and equity, but they have different functions. But one thing that is still um, key in all of this is making sure that we're looking at the structure of everything. So you have your leadership, your coalition building, your assessment choices, you have your intervention and design and implementation, you have advocacy and policy change, and your evaluation. These cycles are actually seen in different levels, but these things are part of the larger structure of foundational and communication building, and also as we're trying to do the work that we do in communities, this is what helps us bring about change and have sustainable change. And so, but everything that you do, we have to measure it and then we have to evaluate it. Because what you want to have is that you're doing all these steps, but then you come back to a point where you're saying, all right, is this working? Is there something that we could be doing better? Is there a different way of doing this? And the way we can come about all of this is working together and to go through all these major steps. And so hopefully, as you're building your coalition, you're gaining your allies. That will help you with recruitment and having a foundation and a resource base. And so this also helps us understand how we should even set the agenda before we even get to what the agenda is. And so that helps us actually have more validity in communities, more access in communities, and then find a way to actually help other people in a way that isn't seen as lecherous, but making sure we're also providing resources back into communities to even address those things that we didn't even come to talk about. But if we could, that's a good way of connecting to your community, is to say, look, we know we came here for a diabetes program, but let us help you be connected to resources that will help you with your everyday life. And so when we're looking at innovation and some of the examples that are connected back to coalition building and building communities and partnering with purpose, social media has been so instrumental with how this all works, especially when we're connecting it back to the resources. And so just having the access of people to talk to each other who may have been through these things, or who are living through these things, or even have ideas to help you, it's a good way. Social media is actually a tool, and the way we use our tools are dependent on the people who wield the tool. So if you have a hammer, you have an option of, you can use the hammer to destroy something, or you can use that hammer to build something. But that hammer is a tool, and that tool itself is worthless without somebody to wield it. So we also look at patient navigation and how it addresses barriers. When I was at Duke Cancer Institute, I was the outreach and screening patient navigation coordinator. And so we were able to be in communities and be that bridge between the community and the health system. And so this is also an innovative approach that helps connect the community to the right resources. And so as you can see in this slide, it helps with also addressing these barriers that people face, and because the health system, or whatever structure or system that we are in, it also can be very intimidating if you have to go through it alone. And so patient navigation has been seen as an innovative approach to address a lot of these barriers. And why can't we use that same type of model when we're in communities and have community navigators and connect it back to the work that we're doing with community health workers? Another type of innovation that I've seen is the dissemination of the dissemination of information to communities. So in this example that you're seeing, a young lady by the name of Anita Woodley was working with FHI 360, and FHI 360 had done a series of focus groups in the Durham area. And what they were able to do was connect with Miss Woodley and have a one-woman play or show where she was working with FHI 360 to take the information from the focus groups and create this one-woman show that had four characters that were representative of the four main themes that they were able to get out of the focus group. It was an innovative approach because a lot of times people come into communities, they take the information, and you never hear anything back about what happened with that information. Well, in this case, FHI 360 was able to disseminate the information back to the community in a free event, and it was open to the public in October of 2014, and it also led to even more discussion of, some of the issues that, or the mindset or the mentality of the community. And so it was one of those things that was very, very awesome to be a part of and see. And we're starting to see more people start to use these innovative approaches about sharing information. And so being a part of this national group called the Patient-Centered Outcome Research Institute, I'm a part of the Communication and Dissemination Research Advisory Panel for that group. It's also known as PCORI, so PCORI. And serving that, I was able to share this story with them, with people all across the country, and they were just saying, oh my gosh, that's a good innovative approach that we should all be kind of using, because it's not a good thing if we do all this work and we even share it with community, but the community doesn't have a way to digest what we're sharing. And so especially in our office, as we are committed to sharing the information of health and health resources, our thing is to make sure that everything that we disseminate is palatable to the community. And so that when the community is connected to it, they understand what it is, and it's not a burden in terms of them having access to it, but also understanding what they're looking at. And one last example is another group that I'm working with. It's called the Southeastern Health Equity Council, and I serve as the co-chair for the Social Determinants of Health Committee. And so one thing that we're doing as well, let me back up. The SHEC is a part of the Region 4 federally designated region of 8 states, being North Carolina, South Carolina, Georgia, Florida, Mississippi, Alabama, Kentucky, and Tennessee, and making sure that we are looking at the issue of food access in these 8 states, and working with a group out of Philadelphia called Uplift Solutions to increase access to capital and eliminate food deserts and food swamps. So I know somebody's probably on the call going to say, well, what is a food swamp? I'm glad you asked. A food swamp is actually those areas that may have food resources but may not be the most healthy of resources. And there are a few places or few stores that you might see, or organizations that you might see in an area of a food swamp. It might be liquor stores, it might be fast food places. You might not have the best access to whole and healthy foods, and so it's a lot of things that can play into it. There have even been cases where studies have been showing that there's some WalMarts will pop up in these food swamps and food deserts, and these food deserts are places that don't have anything. There are no access to any type of good food. So actually in September, we're going to bring some people that are dealing with these issues, especially a guy from Uplift Solutions, but we're also going to bring some people more locally who are dealing with these issues in North Carolina to talk about how, what those issues are and then how we can address those issues. And so that'll be our September Lunch and Learn. So stay tuned for that as well. So as I close, I just wanted to leave you with this thought, and especially connected to what we do. It's a quote from Benjamin Franklin. Tell me and I forget. Teach me and I may remember. Involve me and I learn. So please keep this in mind as we're building our coalitions, as we're working with communities, and we're trying to find a way to connect, that we are involving people at every step of the process. And here's my contact information, and I will take questions because I think we have a few minutes to take questions. But thank you.
Great. Thank you so much, Cornell. That was an excellent presentation. Yes, so we do have time for questions. So just as a reminder, you can type your question into the question and answer section of your GoToWebinar panel, or you can raise your hand. And I see that one person has raised their hand. I'm going to check in to see if they still have their question. Cheryl Halleck, I'm going to unmute you. Cheryl, did you have a question? You should be able to speak. Cheryl, are you there? All right. Well, we'll come back to you, Cheryl. So I had a question about the date of the September Lunch and Learn. When do you have the date for the September Lunch and Learn yet?
Yes, actually, we have the dates for all our lunch and learns, and we have the topics and the speakers for most of them. I think, no, for all of them for the rest of the year. The September lunch and learn is actually going to be on September 6th, so the day after Labor Day, that Tuesday. All of them are going to be on Tuesdays for the rest of the year. We haven't done our calendar for next year, but this year they're all on Tuesdays from 12 to 1:30, and they're all at the Division of Public Health on the Six Forks Road campus, Building 3, 5605 Six Forks Road in Raleigh. But the hope is that we're able to, one, be able to eventually do live stream webinars, and also move them into different parts of the state and communities. And so we'll be staying tuned for that to see how we can get that up and running. But so August, as I said before, we're talking about health professions diversity and the health career pipeline programs in North Carolina. September, we're looking at the food deserts and food swamp and access to capital building in North Carolina and surrounding areas. In October, we're looking at talking about pain, chronic pain, and looking at the opioid issues and innovations to care that are not involved with using narcotics. In November, we're actually going to be looking at community, heritage health, and actually community curators, and how that's connected to our health and well-being. And in December, we're going to have a conversation with Dr. John Hatch, who we look at as a living legend in public health. And so he is one of the founders of the first community health centers in this country. So he'll be coming to have a conversation with us, and people can pick his brain and glean from his knowledge. So hopefully I haven't over-answered the question, but yes.
Great. No, that is great to know what the lineup is for the rest of the year. And so I have written them down. And do you think that you could, when you send me the PowerPoint presentation, if you could send the topic and the date of those, and I can send it out to all of the folks who have registered for the webinar?
Definitely. Yeah, we already have. So what we have the calendar already available that sends you the dates. But what I will do is make a new calendar, a modified calendar for the rest of the year, and try to get that to you as soon as possible.
Okay, so we've got
that will detail what the topics are and who's all supposed to be coming.
Great. So we have a few questions coming in. So one of the questions is, institutions like to call people to their community tables with their own agenda versus going to the community table. You mentioned working successfully in Durham. Whose table were you sitting at? Who was involved, I guess?
Well, that so knowing community is to also know that there are some nuances in community, and so depending on your audience or who you're working with, some things work better than others. I will say in Durham, um, there are many tables that you could sit at. You could be at a faith organization, or you could be connected to the local health department, and because the local health department actually is really good at working with community, and so, but to me, as a collection of that, but also making sure that you can do hybrid type of meetings. But I think it makes really good sense to bring people in to a space where they feel comfortable and not threatened. And so going to them is really key. And so if I'm meeting with a community group, I will definitely just go to them. I've done that a lot in even in all my work I've done, because I've always covered the state of North Carolina, no matter um, well, not always. Well, I was working at Duke. It was more of a Duke connection of where we were. When I was working with the General Baptist State Convention, that work also covered the entire state of North Carolina, like my work does here now. Also, when I worked at American Heart Association, we had pockets where we cover, but always connecting to community and almost letting them dictate terms of where we meet sometimes is more helpful and less threatening than having people just come to you, because the goal is to meet people where they are. And sometimes you may have an opportunity that it's appropriate to meet at a space such as a Duke or American Heart or something like that. But more times than not, it also needs to be reciprocal and reciprocated to respect their space and even meet where they are. So I totally understand the question, but yes, you have to mix it up, because if you keep doing the same thing over and over and over again and trying to expect different results, then you're actually hurting yourself and hurting that community relationship.
So Cornell, I'm going to, that question was from Gina. I'm going to unmute her on the webinar so she can, if she has anything else to ask or follow up on your response or question. Gina, you have been unmuted if you'd like to make any comment. Gina, are you there? Okay, doesn't seem to want to be working. All right.
Any other questions?
Yes, I do have another one.
Okay.
What are some of your measures of success? For example, do you rely on State Center for Health Statistics data to see if gaps in health outcomes by race, ethnicity have gotten smaller, or some other measure?
So the State Center for Health Statistics is a good measure, especially when you're looking for North Carolina data. But even with that, with some of the information that we need, there's a need to rely on more than just them, and so making sure that we're looking at what's the national outlook and what's being reported. So we're looking when we're looking at. So I will say this. Let me put this disclaimer out there. I am not an epidemiologist, but I understand data a little bit. And with that said, when we're looking at data, we can get caught up in looking at the differences of trend data versus kind of yearly data. So trend data is usually like 4 or 5 years um, of data as opposed to 1 year of data. And I have actually warned people to not get too caught up in certain levels of data consumption. The Affordable Care Act, to me, is a good first step to get people access to the services and healthcare that people need. Is it a perfect system? No. Is there improvements that we can make based upon what we've been seeing? Yes. But you have opened the door to millions and millions of Americans to have access to care based on this law. Now, what we're also seeing is, and what I've warned against is that what we're seeing or going to see is that these health disparities that we are looking at in certain areas may even increase because now you have a flood of people coming in with their issues that are now being recorded where before it wasn't being recorded. So I tell people, don't be surprised if some of the gaps widen, and also don't be surprised if some of them shrink. But be prepared for that fluctuation at some point. And so the measure of successes that we're looking at, it's almost a multi-pronged approach. You look at what you can capture. And I think the one thing that we haven't been able to tap into yet is to get everybody on an equal playing field of what they are capturing. So all the systems need to talk to each other. And when you're looking at electronic medical records, and I've actually been trained at Duke Hospital System and UNC Hospital System in what they call EPIC. And so I'm a rare person, I guess. I've been trained in both systems at two different hospitals. Well, same system, two different hospitals, and they kind of talk differently depending on how the interface is. So you actually get to see some of the data that's being collected that historically may or may not have been collected. And so now what we need to do is make sure that these systems talk to each other so we have a better understanding of what these health outcomes look like and what people's issues are going forward. And so once we can figure that out, we'll have a better footing, because you also have Medicare, Medicaid, and all this other data that people are using. You have different levels of systems of health where you have hospital systems, you have free clinics, and you have, different connections, and making sure that we can get it all pulled into the same level of understanding and comprehension.
Great. So we have come to the end of our time. There were some additional questions in the question box. And so what I will do is send those questions to Cornell, and I will get the response and send it back to you. And so I want to just thank you again, Cornell, for this excellent presentation. And we look forward to coming to some of your lunch and learns, hopefully. So thank you so much. And thank all of you for participating today.
You all have a great day. Thank you so much.
Bye-bye.
Bye-bye.